Hello, welcome back. My name is Peter. In the last episode, we talked about late year chart retrieval, specifically the downstream cost that nobody models. What happens to your abstraction accuracy, your member outreach, and submission quality when chart retrieval window closes too late. And so if you haven't listened to that episode, I would go back and start there. It sets up a lot of what we're going to cover today, because here is what I knew would happen after that episode. Someone will listen to it, maybe a quality director, a VP of operations, someone running HEDIS at original plan, and they would walk away thinking, okay, so we need to move faster on digital, get more EMR feeds in place, stand up more CCD integrations, reduce dependency on chart pool, and that is how we get ahead of this. And I get that reaction. It's a logical one. Digital data collection is faster. It scales better. It doesn't require someone to, fax the provider 17 times. On paper, it looks like it's the answer to everything that I described last episode. But I want to challenge that assumption today, because in my experience, the plans that have leaned hard into digital data collection without understanding its failure modes haven't eliminated the problem that I described last time. They've just made it harder to see. Chart retrieval fails loudly. So when a chart doesn't arrive, someone knows about it. There's usually a chase list. There's a vendor escalation. The gap is visible, right? In most cases. Now, for digital data collection, it fails silently. The feed runs, the file will land, the record count looks right. However, the measure still doesn't close, and nobody in the workflow flags it until, it gets to the auditor. The silent failure is more dangerous than even the loud failure. And that is what I'm going to cover today. Let's get into it. The managed care industry has built a mental model over the last 5 years that goes something like this. Digital is good, manual is bad. Digital is the future, chart retrieval is the past. And so if you're still doing a lot of chart retrieval, you are behind. And if you've got EMR integrations and feed agreements in place, you are ahead. And I understand where that framing comes from, because manual chart retrieval is expensive, slow in some cases, and it also can lead to real provider aberrations. On the other hand, the case for investing in digital is also real, and I'm not here to argue against it. What I'm arguing against is the assumption that digital data collection, by virtue of being digital, solves the underlying problem. And the underlying problem is data completeness at the measure level, not at the data collection or at the record level. No, those are two different things, and the industry conflicts them constantly. And here's the distinction I want you to hold for the rest of this episode. Collecting a record is not the same as closing a gap. We've talked about that in the last episode in the context of chart retrieval. A retrieve chart, right, is just a raw material. So getting a chart in a building, in-house, does not automatically closes that gap for that measure. That same logic applies to digital feeds. An ingested CCD is just a raw material. A successful lab feed is a raw material. What matters is whether that raw material contains the right data element, coded to the right measure specification, arriving at the right time in order to support a valid measure abstraction against the NCQA technical specification. Digital data feeds can fail all three of those tests: completeness, coding, timing, and it can fail them invisibly. And that is the conversation that most plans aren't having with their digital data vendors. And that is the one that we're going to have right now. Before I get into the specific failure modes, I want to address something directly. Because if you are operating at a VP level or above in quality or data operations, you are probably already thinking of it. NCQA has a data aggregator validation program, DAV for short, and it is specifically designed to validate data integrity of CCD and also fire data streams used for HEDIS supplemental reporting. DAV validates the data from ingestion at the primary source all the way through to the outbound file. So plans using DAV validated data streams don't need PSV or primary source verification audit. It's a real program and it's also growing. And if your organization is using DAV validated sources, that is meaningful. It cuts off your need for PSV audits, having to chase chart images to validate the CCD feeds or fire data. But here's the precise limitation that makes everything I'm about to still say apply to you. What DAV does is important. I'm not disputing that, in a sense that it makes sure your data flowing from, provider groups, hospital systems into your file did not get messed up along the way. So if a blood pressure reading, for instance, exists in the medical record and it shows up in your CCD file exactly that same way, DAV will say, yes, the data is accurate. And that is what it's essentially designed to do. But here's the problem. And this is where I think most people get it wrong. Accuracy is not the same as usability. Just because the data made it through clean doesn't guarantee or doesn't mean it actually counts for your quality measure. Let me give you a real example. So a patient has a blood pressure reading in the system and it gets put into a CCD file. It passes through a validated pipeline. Everything is checked. Everything looks good. But that reading might be missing the right code or the right context, or it might not match exactly what the measure requires. So now you have data that is clinically real, technically correct, fully validated, and is still useless for closing that particular gap. That is the failure modes no one sees because nothing broke. There is no missing charts, no error message, no obvious gap. Everything looks fine until you run your measure and it doesn't count. That is the difference between what I call loud failure and silent failure. Chart retrieval fails very loud. When the chart doesn't come in, you know you don't have the record. On the other hand, digital data fails very quietly. You think you have what you need, but you don't. And DAV sits right in the middle of that because it guarantees the data moved correctly, but it does not guarantee the data is complete enough to actually count or for you to get credit. And that gap, that invisible gap, is where most plans are losing performance without even realizing it. Let me start with the failure mode I think is most underappreciated. And this is the one that produces the largest gap between what plans believe their data quality is and what it actually is. I call this the completeness illusion. A CCD from an EMR can arrive looking very perfect. Valid data structure, correct member ID, populated fields, clean ingest, DAV validated data stream. Every system check passes. Your dashboard is looking green and is still measure incomplete. Here is why. EMRs are built for clinical documentation. They are built to support the workflow of a clinician in, seeing a patient. It enables them to capture what happened during that visit, what medications were prescribed, what referrals were issued. They are not built to support or to satisfy HEDIS technical specification. Those are two fundamentally different design goals. And the data that serves one doesn't automatically serve the other. Let me make that concrete. So a clinician documents a colorectal cancer screening referral in the encounter notes, right? The referral is captured in the CCD. So your feed picks it up. Your system ingests the data very clean, but NCQA measure specification for COL requires there needs to be an evidence of a completed procedure. Could be a colonoscopy, a fit test, or a stool DNA test coded to a specific value set, right? So a referral, even a well-documented one, cannot satisfy this measure. Although your system ingested the data, the record very clean, the measure did not close it. And unless you have an abstraction logic running at the measure level, not just at the record level, nobody catches the gap. Or let's consider lab data. An HbA1c result arrives in a lab feed. The value set is there, the date is there, the long code is valid and it's current, but the code the sending vendor used isn't included in the NCQA value set for GSD measure for that year, right? Hypothetically speaking. And it's not because it's clinically wrong. It's a legitimate lab code. It just isn't on the NCQA's approved list of value sets for GSD for that measurement year. So your system ingested it successfully. Your abstraction logic did not match it to the numerator. What happens? The gap stays open. The member continues receiving outreach for a measure that has already been satisfied. They've just been coded out of it by a value set mapping problem that lives 2 layers below anyone's line of sight. This is the completeness illusion in practice. So plans look at their lab feed success rates and they feel confident about their data coverage. What they should be looking at is their measure closure rate by data source, and specifically the gap between records ingested and measure closed on those records. For most plans running digital feeds, that gap is larger than anyone has formally measured. And it grows quietly every time NCQA updates its value set in the annual technical specification, while the feed agreement stays static and the abstraction logic continues. The second failure mode is timing. And this one connects directly to what we covered last episode. One of the core arguments in episode 3 was that late year chart retrieval creates outreach sequencing failures. You are contacting members about gaps that are already closed or missing members who need outreach because the data arrived too late for you to act on. Digital data have the same exact problem. The mechanism is different, but the downstream damage is identical. Here is how it plays out. Most digital feed agreements, like let's say EMR integrations, lab feeds, CCD exchanges, they usually run on a batch cycle, weekly, bi-weekly, sometimes monthly or quarterly. That cadence gets set when the feed agreement is signed and it rarely gets revisited. What it means operationally is that data events happening at the provider level don't reach your abstraction system in real time. They reach it whenever the next batch runs. So a member completes a wellness visit on a Tuesday. That encounter gets documented in the provider's EMR. Your lab feed agreement runs bi-weekly. The data hits your system 13 days later. In the meantime, your outreach team has sent 2 more touch points to that same member trying to close that same gap. The member now is annoyed, fatigued. You've burnt outreach budget already, and your closure rate numbers for that member will show an outreach-driven closure when the visit was actually completed, even before the first touch landed. That is a data latency problem, which is masquerading as an outreach success. And it matters because You are making resource allocation decisions. How many outreach attempts to run? Which members gets prioritization? Which measures are still open based on a data picture which is 2 weeks stale by design? Now, scale that across a member population with thousands of active gaps and feeds running on different batch cycles from different sources. Lab feeds on one schedule, EMR encounters on another, CCD updates on a third. So you don't have a real-time view of your gap closure status at any point in time in the measurement year. What you have is a composite picture assembled from batch data of varying ages, integrated manually or semi-manually with no systemic reconciliation of which source reflects the current member status. That is not a digital data strategy. That is chart retrieval with extra steps and a false sense of automation layered on top. Now, let's talk about when there is a source conflict problem, when you have conflicting information from different sources. And this one tends to make operators quiet when I bring it up because it's a problem that is easy to name, but also hard to solve at the same time. And most plans are somewhere between unprepared or underprepared. Here's a scenario. Your EMR feed shows a member had a colonoscopy documented in a specialist notes. Your claims data shows no procedure code billed for that same encounter. A CCD feed from a provider within that same health system shows a referral that appears to have been completed, but the procedure doesn't match the EMR encounter date. The $1 million question that I pose to you is, which source will you trust? Which one would you abstract a code from? You code from the EMR, the claims data, or the CCD. Now, NCQA audit process require plans to document their supplemental data methodology, including how they handle conflicting sources. So technically, most plans have something written down. And I'm not saying they don't. What I'm saying is this: that's what you've documented actually hold up when your auditor tested against real conflicting records? That is a different question. And in my experience, the answer is frequently no, for one of these three reasons. First, the source hierarchy was documented when the plan's data sources were different. Since then, new feeds agreements have been added. Old ones have lapsed, and the documentation hasn't kept up. So the protocol references sources that no longer exist or doesn't account for sources that do. The second reason is the hierarchy is documented at a level too general to guide a coder under real-time pressure. Claims takes precedence over EMR for procedure coding. Sounds like a rule. But what does it mean when the claim shows no procedure and the EMR shows a documented encounter with a specialist who doesn't routinely build the plan? The coder makes a judgment call, and that judgment call becomes your process. The third reason is the protocol exists on paper, but isn't enforced consistently across coders or different vendors. Different coders, different decisions, same conflicting record type. That inconsistency is exactly what a HEDIS compliance auditor is designed to surface. The plans that have genuinely solved this have a source hierarchy that is specific enough to be testable. You can hand a coder a conflicting record and the same decision every time will be made, regardless of which coder handles it. And they revisit that hierarchy every time a new data source is added, every time NCQA updates the technical specification, every time their auditor flags an inconsistency. It becomes a living protocol, not just a document from year one that everyone assumes is still present or is still current. If you're not sure whether your current documentation meets that bar, the answer is probably it doesn't. Because plans who are confident about it are the ones who have tested it deliberately, not the ones who assumes it's fine because it hasn't been challenged yet. Before we wrap up the episode for today, let me be direct about what separates plans that truly have a digital data collection working from plans that think they do. And it all comes down to three things. None of them is related to data feed agreements you have in place. The first reason is they always validate at the measure level, not at the format level. A feed that passes format validation, the correct file structure, clean ingest, no system errors, DAV confirmed data streams. It tells you the data arrived accurately. It tells you nothing about whether the data is abstractable against the measure specification. So the plans that have solved this, they always have a second validation layer that runs downstream of ingest. It's checking whether the incoming data element maps to the current NCQA value set for that specific measure on the chase list. The second layer also catches the value set mismatches, the procedure codes that have aged out of the approved list, the clinical documentation that satisfies the provider's workflow but not the enumerator logic. And without that second layer, your feed dashboard is measuring the wrong thing, and it's just giving you confidence that you haven't earned. The second reason is they've also built a source hierarchy that is specific enough to be enforced, not just documented. And I described it in the last section. The distinction that I want to emphasize here is the word specific. A general rule isn't a protocol. A protocol is something that you can test. And if you can hand two different coders the same conflicting records from different sources, and they can make the same decision, you have a protocol. But if they make different decisions, you have a policy document that isn't driving behavior. The third reason is they treat digital feeds and manual retrieval as one integrated pipeline, not two separate programs. This is the most important one, and the one that fewest plans have operationalized. The members who fall through gaps are almost never fully recovered by one clean data source. There are members where the lab result came in digitally, but the procedure code is sitting in a chart in a specialist note, or where the EMR feed captured the encounter, but not the clinical detail that satisfied that measure, or where the claims shows the service was billed, but the CCD doesn't include the supporting documentation that the abstraction needs in order to close the numerator. Those members need digital and manual retrieval working together. The digital feed to flag the gap, the targeted chart retrieval to close it. Plans that have run those two tracks separately with different vendors, different timelines, and no shared data layer miss those members systematically, not occasionally, systematically. Because the members who need both sources reconcile are disproportionately the ones with complex clinical histories and multiple providers. Exactly the members with the most open gaps and the most impact on your star or HEDIS performance. Here's the question I want you to take back from this episode. Pull your last measurement year's data and look at two numbers side by side. Your digital feed ingest success rate. How many records successfully were ingested into your system, right? Whether CCD, EMR, FHIR data, DAV-validated data streams. Look at the records that were successfully ingested into your system. And also look at the measure closure rate on those same records. How many of those successfully ingested records actually produced a closed gap, right? So the assignment here, look at your last measurement year data. Look at successfully ingested digital feeds. Upon those successfully ingested records, how many of them truly closed the gap? Okay. If those numbers are significantly different, you have a completeness problem, which is running silently in your pipeline right now. It's not a retrieval problem. It's not a vendor problem. It's a data quality problem that lives between the moment your data feed succeeds and the moment an abstractor tries to use what is delivered. And most plans have never looked at those two numbers together. They track ingestion, they track measure closure, which is good, but they don't connect them by source. So the gap between them, which is the real measure of your digital data effectiveness, stays always invisible until it shows up in your stars or HEDIS performance, and nobody can explain why the model was off. That is the work that Podero Health does. We give plans a single execution layer that validates at the measure level. It enforces source hierarchy, and it also integrates both digital collection and manual retrieval into a single pipeline. So the silent failures that I described today get caught before submission, not after, right? It doesn't become reactive, you're proactive. So if you want to see what it looks like against your actual data, your feeds, your measures, your member population, that is what the pilot is designed to show you. Come with your ingest success rate and your measure closure rate by source. If you don't have those numbers yet, that is exactly where we start. The link is in the show notes. And if this episode connected the dots between something you have been seeing in your data and something you haven't been able to name, share it with whoever owns data quality operations at your plan. That is the conversations that I want to be part of. See you in the next one.
1, 2,